There are, though you are not using peritoneal dialysis, but probably I would say it's kind of a bread and butter for us. And most of our patients are small, they are probably not afford. And a lot of times we have a problem with the access also. So I'm going to slowly talk about it, but in between I might ask some questions. So when we summon our friends is basically when we know there is an obvious kidney injury, and probably there are certain times we don't have obvious kidney injury. So what we try to do is we try to ask them whether they can help up with a lot of other things, and we are going to talk about it. So this is three way we can think about dialysis. Either it's an emergent, urgent rescue therapy, or elective therapy. Most of the times in ICU what we see is kind of an emergent or urgent therapy. And these are the common things we use, as Dr. Kanav has talked about. Specific indications, we are going to touch base a little bit about some specific indications, but the most important thing is peritoneal dialysis. The way we see dopamine and dobutamine are fall of a giant in the sepsis and septic shock. Same thing, peritoneal dialysis is also losing its kind of a charm in the acute ICU setting. But we do use it very commonly. So this is a question for all of you, though it is related to pediatric. The commonest indication for peritoneal dialysis in the ICU, anybody can choose? So definitely means we might say acute kidney injury would be the things, but commonly it was used since long time for fluid overload, rather than whenever it is good more than 20% of your actually total body volume in a day. So we think about removing because all the studies suggest in a pediatric population, if your positive balance is more than 20%, the odds of mortality increases by 3 times. So the commonest one is fluid overload, not kidney injury. So we do it more frequently when we really wanted to control and we don't have a dialysis machine. So as we told about, we have acidosis and fluid overload. Sometimes in a distal electrolytemia also we think about peritoneal dialysis. And there are sets of other peritoneal dialysis indications, ambulatory, automated. I'm not going to touch upon because this mostly on the kind of on home settings or chronic settings. So we know the functions mechanisms remains the same. There is not much of a change. The only thing is a membrane is your peritoneum here, and we are trying, actually we are extrapolating a lot of kind of a knowledge that the peritoneal fluid is going into that and it's going to bring the desired change what we want, but it not happens almost similarly. So sometimes we don't get ultrafilter and we have to play and change with this peritoneal fluid. So sometimes we see a lot of this sepsis, septic shock patient, we start peritoneal dialysis because of the financial constraints and they have acidosis. So what to do? So there is a solution A and B which we have to prepare and actually make it and start peritoneal. Basically you can say bicarbonate containing kind of a PD fluids. And we are sorry that we don't have this available in the out settings. You can actually summon the pharmacist, he prepare in a very sterile environment and get you. But here we have to make it. But it is nothing more than a kind of a giving a slow bicarbonate infusion basically. So what we are trying to do, we are all debating that don't give bicarbonates in sepsis and septic shock, and what we are doing is we are actually trying to do the same thing, intracellular acidosis. So basically though it creates the acidosis very good, but it's not kind of a really recommended. It's like a slow bicarbonate infusion and cause paradoxical intracellular metabolic acidosis, and there are high chances of infection. So almost we don't use it unless and otherwise it's absolutely a desperate situation. And so other things is we know that if you wanted to increase the concentration, if you wanted to get a lot of negative balance, what we do? So there are few osmolar agents we can use. One of them very good osmolar agent is urea, but it doesn't make sense in putting the urea into your actually peritoneum. So what we do, we use dextrose, and dextrose is really helping us, but associated other complication comes. So we have 1.7% which is standard, then 2.5, 3.4. How much ml should be added into the peritoneal fluid to make it the desired concentration, I'll tell you. But to improve the kind of removal of this fluid or probably a dialysis, what we do, we try to give more dwell kind of a volume. At the same point of time, we try to keep a reasonable dwell time. We don't try to extend it too far or too less, and most commonly we use 1 hour cycles. We'll talk about it. And yes, definitely when you're thinking about hematoma or hemoperitoneum, peritonitis, it's not a good modality. So what we do, as we do, so we know that if our standard is 1.7%, and if you really wanted to make it 2.5, you can add 32 ml of 25% dextrose, 3.5, 72 ml, and almost 100 ml if you wanted to make 4.25% of peritoneal volume. Dextrose concentration, so that you can get a more ultrafiltrate. But it comes with a lot of things like a sclerosis. And lot of our patients are on high inotropic doses, so we exactly don't know what is happening at the capillary level. All capillaries are shut down, and whether we are able to do the effective clearance, we don't know. So we really have a lot of hypotheses when we are using a peritoneal dialysis. More than 10 kg, we use adult dialysis catheter because we really want it to be stiff as well as open. Less than 10 kg, we use pediatric, and same standard solution we use it. Sometimes in a known situation where we know that is a chronic renal disease patient coming in acute situation and child is fine, we try to think about soft TANCOF catheters, which has to be done in the OT with the omentectomy, and we use the standard PD fluids concentration. So again, we get the, what we exactly do is we create, if there is a good ascites, we go directly. If it is not, we create an artificial ascites by putting a small IV cannula around the umbilicus. And we use periumbilical, most of the time supraumbilical, and goes into the left paracolic gutter and try to go inside. And we make a, I would say, connections like that we don't have to touch here. It is just a matter of this dosimeter. We can actually close and off so that we are doing a continuous peritoneal dialysis. Even this out, we put it into the urinary kind of a urometer so that there is no touch technology, and we just can pour it out and free fill it again and again. So again, there are units, we have an automated PD cycler, we use it and it's really good. Basically, when the patients are acutely sick, we don't use that, but when they are relatively improving and they need a little bit of longer peritoneal dialysis support, we try to use that. Most commonly used dwell time, as I told, 5 minutes in, around 45 minutes dwell time, and then we try to remove it. This is commonly used. But if you ask me about any literature related to that, you will see a very less literature, because most of the literatures are related to the chronic CAPD, which we do it in the ambulatory patients. So when commonly we see in the ICU, the child comes with the sepsis, septic shock, lot of hemodynamic instability, would PD is a good option to start with, because like if we wanted to prime the circuit and start dialysis, we see a lot of times the child is deteriorating suddenly, even in spite of starting having a blood primed circuit and all those things. Does PD makes the sense? So as we discussed, most of the time, probably I would like to completely take over the child situation as compared to be believed on the peritoneal dialysis, because we don't know what is exactly happening in the capillary membranes. So I would prefer to be on the CRRT rather than on the peritoneal dialysis. So that would be my choice. And there are a lot of things, I have gone through a lot of units, pediatric units, and there are different practices they do it. They call it rapid cycling. The moment they put a PD, they will do in and out for 5-6 cycles. Does it have any significance? So no, it doesn't have any significance in the initial phase, just to kind of whatever the artificial things you have created, there might be a little bit of bleeding. So you can do that. Usually use 1 hour cycling, and antibiotics and heparin are really added into the peritoneal dialysis fluid. It's a common practice, though somebody will accept or not, but it's a common practice. But there are no specific indication for that, and there is no studies which suggested that it improves or decreases the chances of infection or it will not get clotted. And there are units when we are actually struggling with the finances, that the stillet which we put the peritoneal dialysis catheter, they will keep it and they'll keep on reintroducing it because there is a momentum coming and actually clogging this. So this is also not a good practice. And if you have really this struggle coming, so you can actually remove that catheter and put a new catheter. So again, these are some practices which probably not. And about the drug modification, as Dr. Khanna has already said, you can use the standard guidelines, but really important, you use your creatinine clearance specific antibiotic. And sometimes in the patient, if you feel the improvement is not good, you can add 10% of additional dose. So if the PD catheter is blocked, what we would do, the best thing is remove that. If it is acute, like done in the last 6 hours, remove it and go into the same place. Or if it is like more than 24 hours, you remove it. If there is no peritonitis, you take a different position and go back. This is quite common for us because of the big amount of momentum which we have in a pediatric population and the less space. So complications, one of the very important complications which we see in our peritoneal dialysis patient is they are on actually ARDS and a lot of other ventilatory things. The peritoneum goes up, diaphragm goes up, and we have the ventilatory issues and hypoxemia related to that. Second thing is infection, which is quite common because we really have to have a very thorough system which there is no chances of infection. These are the two things we really struggle. Bleeding, even if the INR is high, most of the time we don't get it because we go through that aponeurotic junction where actually there is a less of the blood vessels. Timeline. So if you can continue peritoneal dialysis, there is no infection for 7 to 10 days also. But after 10 days, we feel there is an established renal injury, we try to get the consent and send them for the soft catheter TENCOF, which is usually done in the OT with the omentectomy because we really have to do it for the longer time. Now, with peritoneal dialysis comes the other allied extracorporeal therapies. One of them is therapeutic plasma exchange, which is quite commonly used in the pediatric population, and one of the commonest indications, because as all of us know, we have to clear the larger molecules, and most of us are targeting about IgG here. We really wanted to remove that because it has a high half-life is pretty bad. It's like almost 21 days to 30 days. And what is happening is all the modalities, immunosuppressions and all those is going to take time. So we really want an acute kind of an improvement. We know that there are two plasmapheresis. With the onset of this membrane, new filters, the like I would say, the centrifugation technique has already gone away, except in the few of the leukopheresis and all those things we are doing it, but the most of the time we are following this plasmapheresis filters. So what would be the commonest indication of plasmapheresis in the pediatric population? Good. So it's LGBS, and second is HUS. So LGBS because the cost, if you see IVIG 30 kg child would cost IVIG around 1.2 to 1.5 lakhs. And plasmapheresis is found to be really effective, specifically if it is done in the first 7 days. There are kids in our follow-up, we have done it in the first 3 weeks, they said it's a good response, and we have done at least 5 times, and the second 7-8 times also with the good improvement in them. So this is really important if you really wanted to prevent the extent of injury. And you know all about large and small plasma exchange. Most of the time we are talking about a large plasma exchange. They remove antibodies, specific factor. Why this is really important in the pediatric population? One of the commonest indication, as Sir said, is D negative HUS. And it is different than the other things. In here we have to use a fresh frozen plasma multiple times in this patient. The moment we make a diagnosis of D negative, we keep on giving them fresh frozen plasma, and whatever the replacing fluid we use it in this therapeutic plasma exchange, we use it FFP rather than the other things, because we really have to maintain that factor in the bone. So this, all of you know about this, but again that don't use immunoglobulins before doing a therapeutic plasma exchange, because we are going to remove it, or immunosuppressive agent. But there are a lot of conditions we have seen in the last 1 year. One of the commonest and deadest things we have seen in the pediatric population is MISC, multisystem inflammatory syndrome in children. Here we went really aggressive, and we have some patients under follow-up. One of the very bad MISC I have seen, and we did plasmapheresis, steroid, and IVIG, bang, 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 for the 5 days. We kept on giving, finances were not an issue, and the child improved, because this was really, CRP was in 400, ferritin was in 1 lakh, the child was having complete rashes all over the body. So, though the science says you are going to remove it, but remember why we are giving IVIG. If you go into the literature of IVIG, at this moment we are just assuming that this immunoglobulin is going to go and going to attach to the targeted immunoglobulin which we wanted to remove it. So, if it is a matter of life, I would do the things bang, bang, bang. And most of the time, 4 to 5 times plasma exchange is good, and we will be able to take care of all of this patient. And as we discussed in a D negative HUS, we make it sure that the replenishing fluid is FFP. And what about this? Should we do therapeutic plasma exchange with other things? Like, can we do it with the ECMO? Can we do it with the CRRT? Yes, we can do it, and we have done it in the pediatric population. I'm going to share those videos. As we know, this rationally is very clear. We wanted to clear this IVIG, and other things are going to take time to kick in, so that the improvement is going to take time. These are the few other mechanisms which the therapeutic plasma exchange helps, and one of the commonest one is clearance of antibodies. This is the way we calculate the dose. You can see 10 kg child considering hematocrit is 30%. So you calculate the plasma volume, which is total blood volume, 1 minus hematocrit, which is kind of a 0.3, so 0.7. So out of 80 ml per kilo, almost 560 ml, which would be out of 800 ml, 560 ml is our plasma volume, and we try to remove 1.5 times of this when we are targeting the plasma exchange. And this is in Kaplan's equation, but most of the time we use this formula. And these are the molecules which has in presence in the intravascular compartment, and we try to target that percentage of removal with the each plasma exchange. So almost 1 times we remove 63%, 1.5 77%, and by most of our plasma exchange are targeted around 1.5 times of the plasma volume, and we do it for 4 to 5 cycles. So same thing as I told, 1.5 plasma volume exchange is the usually preferred one, and we keep on doing it over the 4 to 5 sessions. So our unit, depending upon the finances we choose it, if it is a kind of we are using a Fresenius machine or 4008, it's a manual, so we have to really manually regulate how much plasma we are removing it. And we have to maintain the same is going in, but in a Prismaflex, it's kind of really automated, and we don't have to really think about it. So what we do calculate the dose of plasma exchange in pediatric, we choose the circuit and machine. Priming, if it is less than 10% of the total body, most of the time it is more than the 10% of the total body volume, we usually prime with the blood. Regional anticoagulation heparin, depending upon the coagulation status, if the child is having high INR, we try not to give it. And we closely watch on the calcium. We give a medication dose immediately after, like antibiotics and all those things, immediately after finishing the therapeutic plasma exchange, and we do all cover with the appropriate calcium at the end of the procedure. So this would be the actual prescription looks like. We have body surface area, hematocrit, total plasma volume. Usually we try to remove in 2 to 3 hours, and we divide that plasma volume by 3 or 2. Post-filter replacement fluid was given, and make it sure that the heparin is properly taken care of. Different filters which are readily available at this moment. The only thing here is about this, which is Baxter. We can use it more than 9 kgs. So this is a child who is actually on ECMO because of the gram-negative sepsis, and subsequently started having hyperbilirubinemia. E. coli sepsis, where the bilirubin went up to almost 40-45, and child was having high inflammatory markers. So we actually try to do a therapeutic plasma exchange on ECMO. So you can see this is post pump, it is connected. 4008 was used. So flow is not an issue here because you are already on a huge amount of flow, almost 1.2 liters per minute. So post membrane, we have given this in, and this child definitely improved. Over the time, this child went on VA ECMO because of the cardiac, and subsequently came out of this. Then for us, the bread and butter is multi-organ dysfunction, sepsis and septic shock, and we see a lot of kids with ICU, and as we discuss about oxyrix, cytosorb and hemophil, definitely there are certain patients we have used cytosorb, but our understanding about cytosorb in pediatric, if you ask anyone, is still keep on evolving. And I had a lot of question in the previous session because I have used it cytosorb for 4-5 hours, child has improved, and 7th hour child deteriorated. There are case reports on their site itself, they says use it for 24 hours. And we have tried to use, there is no response, and there is a complete discordance between ferritin, endotoxin, and IL-6. So here, this was a child who was really kind of a bad, and there are multiple studies is try to remove. We know we have been extensively discussed, and this was a child who was having a very bad sepsis, E. coli, multi-organ dysfunction, hyperlactatemia, but had kind of a little bit of maintained urine output and going in early AKI. And what we did is, we know that about cytosorb, good cytokines, bad cytokines, and most of the times we assume that depending upon the concentration level, we are trying to remove it, and I believe there is a lot of discussion about it. But definitely it comes with the cost, and there are good cytokines which are also getting, and as the previous session somebody pointed out, tissue level of cytokines is more important than the blood level. So we know less about it. So this is that cytosorb score. We commonly use it when we are thinking about, and as the previously also Dr. Patrick said about the timeline. So yes, if I wanted to use, how I counsel the parents is, if you wanted to use now. If tomorrow you ask me to use, I would not use it. So we try to use it early rather than a late. And other modalities is, if they require some kind of a dialysis support and all those things, there are options of Oxyrix which we can think about it. So this was the same child on CRRT as well as cytosorb. This child received almost 5 sessions of cytosorb and subsequently child improved. This was a connection. Video is playing nicely on there, but there is a lag, I think so, between the... Excuse me? There is a lag. So again, it's just kind of putting into that series circuit where cytosorb and CRRT have. There was a question about whether we can, sir, Dr. Khanna has asked about it, but what challenges we have faced when we are using cytosorb for longer time is it's at a huge surface area. So the requirement of anticoagulation goes up pretty high, and if because of the anticoagulation, if the circuit gets clotted, you lose your cytosorb as well as things together. So means again, if it is running nicely, you can keep on using it. About heme adsorption, we definitely use recently, Dr. Nayan has used, we had a child with unknown poisoning, probable lead poisoning, and what we used is charcoal heme adsorption is commonly used, but we landed up in a situation that all the lots in India were not functioning nicely, so we have to use the resin for this child. Again, a very good modality. Commonly what indication we see in pediatric practice are phenytoin overtoxicity. There are a couple of indications like mercury poisoning, like a lot of parents try to give homeopathic medication. Excuse me. Achha, sorry. Okay. So they try to give homeopathic medication which contains a very high level of mercury. So that's why. And this is a child who was actually with the phenytoin toxicity, went on charcoal heme adsorption. Most of the time, 2 runs would be fine and they would take care of, and in India, if you send the phenytoin levels, it will take at least 5 to 6 hours to get the phenytoin levels value. So it makes the sense to, if there is a high index of suspicion, start as soon as possible. So similar, nothing, urinary output is so kind of a similar setting as a therapeutic plasma exchange. And then we have this child with, recently, whether we can do dialysis or SLED with kind of a plasmapheresis, because if we use cytosorb, it's a lot of money. So can we do that? And we did this experiment, Nan was with us when we did that. The child came in a pretty bad shape, high ferritin, high CRP, vasoplegic shock, high vasopressin, epinephrine, everything was there, and child was deteriorating in front of us. And what we did is, so we kind of put both in the parallel circuits. Not parallel circuit, series circuit. So first through the SLED, and so it was a right IJ catheter. You can see this is, plasma is coming here, and this is a plasmapheresis. So you have this. After this dialysis, it's going back into the plasmapheresis and removing. With this small kind of a things, we were able to save almost 40 to 60,000 of this child. And the child did showed some improvement in the next, but over the time we lost this child because the child had a really bad vasoplegic shock. but child did show stability with improvement in the inotropic support. Oxyrase, yes, we have used it. The only problem here is we cannot use in a smaller child, more than 30 kg. So we still have a lot of limitations related to that, including cytosorb. They said more than 20 kg, less than 20 kg also, but we have used in 8 kg child also, but again had a lot of issues related to anticoagulation. We know a lot about this, and this is a child on CRRT and ECMO together. Again, this child came with a bad influenza B sepsis, went on VA ECMO, and had really a bad renal injury. So you can see there, this is actually a pre-pump and post-membrane. There are a lot of permutation combination, but depending upon what cause alarm, what doesn't cause alarm, we use this. Otherwise, we'll keep on putting on that alarm everywhere. So this child did showed improvement, came out of the CRRT as well as an ECMO. We did it for another 3 kg child who went on VA ECMO and CRRT. So this is about some kind of extracorporeal therapies we use in a pediatric population. I know the timing is less, but yes, we still have 5 minutes for questions. Thank you.